All right. Good afternoon. I'm sure we're gonna have some people straggling in shortly, but we are 5 minutes past the starting time. So I'm just gonna launch into it. Just to start, this is an official naloxone training certification, if you will, certified by myself at Marchese Pharmacy. If you want to receive your certification, just download this form, complete the registration. We will send you your training certificate by email after the session is done. Also, that training certificate that you receive, you can use it to go out and pick up your own personal pair of naloxone kits at Marchese Pharmacy. We're just located on James Street, north of Barton, where there's lots of nice cafes and restaurants if you ever want to sample the fare here in our fair city of Hamilton. So I will post that again later on, maybe at the end of the presentation, in case anyone still needs that. But let's proceed. Okay, hopefully you can all see this slide in the audience, and welcome to those of you joining remotely. My name is Faisal Khawaja. I'm a pharmacist of 31 years. Most of that time I've practiced in Hamilton. I do have a couple of practice locations around Southern Ontario. Much of my career has been dedicated to managing substance use disorders. And in the last, I'd say 15 years, obviously the opioid crisis has become quite prevalent in our country and sort of across the world. And so one of the things we're trying to do is to provide meaningful education on some of the causes of the opioid crisis, some of the historical context and current context, as well as some data and stats that might be useful to you in your careers down the road. But as a foundation, hopefully you'll find this session useful. So the title of the talk is Learn to Save a Life, Opioids and Naloxone. Some of our learning objectives include, we're going to talk about how bad is the current crisis, what are some of the things that have contributed to it, and who is affected. We're going to review some basic biochemistry, not going to be in too much detail, some pharmacology, as well as we're going to look at what are some of the risk factors that increase the chance of a person dying from an opioid poisoning, as well as we're going to talk about the opioid use disorder diagnosis. We're going to touch on stigma, trauma, and resilience. We're going to look at what public health strategies have worked and have not worked around the world. And we're going to end with how to use naloxone to save a life in a rescue situation. So why does it matter? It matters a lot. In Canada, in 2021, more than 8,000 people died from opioid-related causes. Just for a little context, that's more than 5 times the number of people who died from motor vehicle accidents in the same year. So it's an incredibly high number. Ontario and British Columbia tend to be disproportionately affected. They're sort of the hotspots. There are other hotspots around the country. And even within a province, there are certain municipalities and regions that are disproportionately affected. Hamilton is one of those. We're consistently higher than provincial average. So this is the declining scale based on the efforts, energy, resources put into diminishing the impact of motor vehicle fatalities in our country. We've all heard of Mothers Against Drunk Driving, as well as numerous other programs. But this is the chart that shows the number of opioid-related deaths in the city of Hamilton alone. You can see starting in 2015, it starts to gradually increase. And then around 2015, 2016, it starts to spike dramatically. This correlates with the entrance of fentanyl and fentanyl analogs in the street drug supply in our city and across Canada, really. And you can see that it peaked in 2021. That was, of course, a COVID year. And we did see a slight drop off in 2022. It's probably more of a COVID correction than a true organic decline in the rate of opioid deaths. So these are, this is kind of some bullet points from a study, a retroactive study that was conducted by the Institute for Clinical and Evaluative Sciences in Toronto, along with St. Mike's Health System, where they found that of the people who had died from opioid poisonings in the prior 12 months, that fully 1/3 of those people held active prescriptions for opioids, that 75% of them were prescribed opioids in the prior 3 years. Okay, so this melds very well with us, with the concept that we understand most people get their first exposure to an opioid through a legal prescription, either from their doctor or their dentist or their nurse practitioner. More than 40% of those people had sought mental health support in emergency departments in the prior 3 years. So we're seeing them. They're coming to us, they're asking for our help. It doesn't appear that they're getting the help that they need, and certainly not the continuity when they are released back into the community, the continuity of care that they require in order to manage their conditions. So as health professionals, we have a great task ahead of us, and we need to be doing better. In terms of ages that are affected, you can see from this chart, the largest group that's affected is between the ages of 25 and 55, primarily males. Okay, so 75% of people who die from opioid poisonings are males. There might be a number of reasons that we get that kind of correlation, not the least of which I would suggest is the fact that fully 1/3 to 40%, roughly, depending on the year that you're analyzing. In terms of employment category, the single largest employment group that is affected by opioid poisoning deaths is the construction and skilled trades. Okay, so between 33 and 40% of all opioid poisoning deaths that can be correlated with an employment status are in the construction and trades. Very often these are injurious jobs. They are precarious jobs. So, and they're heavily stigmatized by those who are not working in those fields. They tend to be looked down upon by certain groups of people in our society. But the bottom line is, if they're injured on the job, which happens very often, depending on the extent of the injury, they may choose not to tell their foreman that they're injured, because to do so would mean that they would not be called to work, would not be allowed to work, and they don't get paid, so they won't be able to support their families. So for this reason, they'll often just go to their friends, their colleagues, and they will share their opiates, so Percocet, whatever they might have. And unsupervised opioid use is always a recipe for trouble. So very often they get into trouble that way. So this is just one possible reason why males are disproportionately affected. For the skilled trades or construction sector, overwhelmingly male, more north of 95% of our males working in that sector. So who is at risk? This is a very good question. We often think that it's a street drug user in a back alley, okay? That's what comes to mind very often based on maybe media that we've consumed or what various media sectors might like to propose to us, even politically. We're pushed certain ideas. But the fact of the matter is that anywhere that an opioid exists, there's the potential for an accidental poisoning. Even the person who's prescribed, I don't know, hydromorphone, okay, appropriately for a legitimate pain condition, and they're dutifully taking their medication. Those tablets are very small. It's not unheard of that one tablet might be dropped unwittingly by the patient. And if there's a small child in the house, like an infant, we know that infants explore their world through their mouths. So they're likely, it's very possible that they might ingest that medication, and then you have an opioid poisoning, accidental opioid poisoning. The vast majority of opioid poisoning deaths are accidental, in 95%. This is an actual prescription that was presented to me on a Saturday that I was working at my pharmacy. And it's difficult to read, but I'll read it out for you. It's written for hydromorph content, 30 milligrams PO, that's by mouth, twice a day for 30 days. And dilaudid 1 to 2 milligrams, which is also hydromorphone, by mouth every 4 hours. That would be, PRN for breakthrough pain, and then stool softener. So this prescription was brought in by an elderly gentleman on a Saturday. And because I've worked in chronic pain and palliative care for most of my career, my sort of automatic response is to find out what the prescription for his wife. Okay. Find out what opioids she's currently on so I can convert the dosage to make sure the dosage is correct. So I asked him what opioid she's currently taking. And he said, oh, she's not taking any opioids right now. She's never taken opioids. She broke her hip. She's in the hospital. She's being discharged today. It's her first time getting an opioid medication. So if you're not familiar with pharmacology and pharmacology of opioids in particular, this is a very high dose for an opioid naive patient. I picked up the phone, I paged the prescriber, and they called me back pretty much right away. Sounded a little annoyed. Okay, I paged them, and I explained the situation. I said, I've got an opioid naive elderly woman prescribed hydromorphone 30 milligrams twice a day. And she said, oh my God, I meant to write 3 milligrams twice a day. Okay, so erroneous prescriptions are written every single day. Pharmacist's job, one of our jobs, is to make sure that we screen every prescription that comes through for appropriateness for an individual patient. In this case, we identified it, contacted the physician, made the change, and for sure this patient would have had a poisoning event, for sure. Okay, so even appropriately prescribed or what appeared to be legitimately prescribed opioids can result in a poisoning event. Even if the dose had been 3 milligrams, there's not 100% certainty that a person will not individually, on an individual basis, not experience toxicity based on what is a standard dose for the standard population. Okay, there's any host of reasons. Elderly person, maybe kidney impairment, renal impairment, liver impairment, their ability to process those medications and eliminate them is impaired. Also, pharmacogenomics can play a part, depending on the isoenzymes in the liver that are responsible for breaking down particular drugs. The person may express a greater or lesser degree of those isoenzymes, resulting in their ability to accumulate those medications to a higher degree. So anywhere that an opioid exists, whether it's on the street, legally, prescribed or otherwise, there's a potential for a poisoning event. So what are some of the things that increase the risk of death from using opioids? If a person is injecting their opioids, it's got more immediate access to the blood supply and then can cross into the brain that much more rapidly. If they start using a different opioid than their body is accustomed to using, if they take higher doses than they're accustomed to using, and if they have other health conditions, like I mentioned, liver impairment, kidney, or even lung conditions, respiratory conditions, we know that opioids in high doses and toxic doses cause respiratory depression. Okay, that can lead to death. Furthermore, if a person uses drugs that are bought on the street, as opposed to those that are of pharmaceutical quality and commercial supply, we know exactly what and how much is in each of those doses. We don't know what's in the street supply. And frankly, street supply right now is extremely toxic and extremely heterogeneous. And that's posing the primary problem on the street. When opioids are combined with alcohol, sedatives, or other drugs that can also act as respiratory depression, the effect can be multiplied. If the person hasn't used in a while, for example, if they've been in jail, or if they've been clean, if they've been off of opioids for some time, their body has lost tolerance or the ability to process the way that they normally would, and therefore they're at higher risk as well. Not having naloxone on hand. Okay, we're going to talk about naloxone in a few minutes, but if not having naloxone on hand obviously impairs our ability to reverse the opioid poisoning. And using alone. And I mentioned using alone last because it is extremely important to know the vast majority of people who use drugs use alone. And it's not rocket science to understand if there's no one there to help you, your risk of death increases dramatically. And about 70% of those people who use opioids also use multiple substances, whether they're stimulants or other depressants, benzodiazepines, okay, Valium, Xanax, etc. So it's not always clear when you encounter somebody that could be experiencing what appears to be in distress or in a medical emergency. It's not always clear exactly what they've consumed that has caused them to go into that state. So at this point, we're not actually looking, you're not finished your schooling, you're not licensed to practice. You're not going to be expected, just as I would if I was training members of the lay public. You're not expected to diagnose this person. You're just going to look for the signs, okay, that I'll describe in a few minutes. And then on that basis, you will determine whether you're going to act or not. Right? So it's very simple. Because again, we won't know exactly what they've consumed. If they're unconscious or unresponsive, we won't be able to tell you what they've consumed. Why do people use alone in the first place? So these are user responses. They describe that it's more convenient for them. They feel more comfortable when they use alone. Very often, and we know this, they're stigmatized for their drug use. And so they're often hiding it from their friends, family members, coworkers. And so there's no one else around. They don't feel stigmatized. They feel safer. Right? If you're in possession of something that other people might want, they might assault you. They might rob you in order to get that. So it's safer not to have anyone else around. And they don't feel any pressure to share it with anyone else. You know, if you're in a social setting, we're social creatures. So we often feel pressure to share something that we have that another person might want. And most of the time, people are using their private residences. They're not in a back alley. Okay. Most of the time, 95% of the time, this number comes up a lot. They're in their private residences. They're in their home. They're in an apartment. Okay. And during the pandemic, in 3 out of 4 deaths, there was no one present to intervene. So they had no hope that anyone was going to be able to reverse it quickly and effectively because there was no one else present. They were using alone. The National Overdose Response Service, I don't know if you've heard of it before, but I'm hoping that you're going to remember this name. National Overdose Response Service, or NORS, is a Canadian national program founded by Grenfell Ministries right here in Hamilton. It's the only program of its kind across the country and allows a virtual way for people who use drugs not to use alone. So what they do is they call the number, they get a response from a peer support worker, someone who has lived experience with drug use, and they give them their address or an emergency contact number and or permission to call 911 in the event that they fall off the call or drop off the call during the course of their drug use. Okay, so it's a virtual buddy, a way to virtually not to use alone. This program has been groundbreaking. The utilization is going up dramatically, and it's just one of the things that I feel like everyone should know about. If you know someone, patient, a friend, a family member that uses drugs, make sure they know about this service. It's completely free. It's funded through SUAP grant from federal government of Canada, which is supposed to be renewed before the end of the month, but they don't even know if it's going to be renewed. So we don't know whether this program will be continued. Shocking. This is how government programs work, unfortunately. But NORS.ca, please remember this. So I'm going to run a video. Hopefully we're going to get audio here. Oh, I know what that got to be. All right, I'm going to stop this momentarily. When I share a screen, I have to share my sound. One more time. Okay. So there's a YouTube video you can watch. It's Mike Davis, an American fellow, produced it. It provides some good background information and understanding, some context, and visually it helps to understand a little bit as well. So hoping that it can launch. Come on. Oh, of course you won't. Okay, plan B.
More than 3,000 years ago, a flower began to appear in remedies in ancient Egyptian medical texts. Across the Mediterranean, the ancient Minoans likely found ways to use the same plant for its high. Both ancient civilizations were onto something. Opium, an extract of the poppy.
Yeah, I did share the Steve pause now. What's that taking? Yeah.
More than 3,000 years ago, a flower began to appear in remedies in ancient Egyptian medical texts. Across the Mediterranean, the ancient Minoans likely found ways to use the same plant for its high. Both ancient civilizations were onto something. Opium, an extract of the poppy in question, can both induce pleasure and reduce pain. Though opium has remained in use ever since, it wasn't until the 19th century that one of its chemical compounds, morphine, was identified and isolated for medical use. Morphine, codeine, and other substances made directly from the poppy are called opiates. In the 20th century, drug companies created a slew of synthetic substances similar to these opiates, including heroin, hydrocodone, oxycodone, and fentanyl. Whether synthetic or derived from opium, these compounds are collectively known as opioids. Synthetic or natural, legal or illicit, opioid drugs are very effective painkillers, but they are also highly addictive. In the 1980s and 90s, pharmaceutical companies began to market opioid painkillers aggressively, actively downplaying their addictive potential to both the medical community and the public. The number of opioid painkillers prescriptions skyrocketed, and so did cases of opioid addiction, beginning a crisis that continues today. To understand why opioids are so addictive, it helps to trace how these drugs affect the human body, from the first dose through repeated use to what happens when long-term use stops. Each of these drugs has slightly different chemistry, but all act on the body's opioid system by binding to opioid receptors in the brain. The body's endorphins temper pain signals by binding to these receptors, and opioid drugs bind much more strongly for longer. So opioid drugs can manage much more severe pain than endorphins can. Opioid receptors also influence everything from mood to normal bodily functions. With these functions too, opioids' binding strength and durability mean their effects are more pronounced and widespread than those of the body's natural signaling molecules. When a drug binds to opioid receptors, it triggers the release of dopamine, which is linked to feelings of pleasure and may be responsible for the sense of euphoria that characterizes an opioid high. At the same time, opioids suppress the release of noradrenaline, which influences wakefulness, breathing, digestion, and blood pressure. A therapeutic dose decreases noradrenaline enough to cause side effects like constipation. At higher doses, opioids can decrease heart and breathing rates to dangerous levels, causing loss of consciousness and even death. Over time, the body starts to develop a tolerance for opioids. It may decrease its number of opioid receptors, or the receptors may become less responsive. To experience the same release of dopamine and resulting mood effects as before, people have to take larger and larger doses. A cycle that leads to physical dependence and addiction. As people take more opioids to compensate for tolerance, noradrenaline levels become lower and lower, to a point that could impact basic bodily functions. The body compensates by increasing its number of noradrenaline receptors, so it can detect much smaller amounts of noradrenaline. This increased sensitivity to noradrenaline allows the body to continue functioning normally. In fact, it becomes dependent on opioids to maintain the new balance. When someone who is physically dependent on opioids stops taking them abruptly, that balance is disrupted. Noradrenaline levels can increase within a day of ceasing opioid use, but the body takes much longer to get rid of all the extra noradrenaline receptors it made. That means there's a period of time when the body is too sensitive to noradrenaline. This oversensitivity causes withdrawal symptoms, including muscle aches, stomach pains, fever, and vomiting. Though temporary, opioid withdrawal can be incredibly debilitating. In serious cases, someone in withdrawal can be violently ill for days or even weeks. People who are addicted to opioids aren't necessarily using the drugs to get high anymore, but rather to avoid being sick. Many risk losing wages or even jobs while in withdrawal, or may not have anyone to take care of them during withdrawal. If someone goes back to using opioids later, they can be at particularly high risk for overdose, because what would have been a standard dose while their tolerance was high can now be lethal. Since 1980, accidental deaths from opioid overdose have grown exponentially in the United States, and opioid addictions have also exploded around the world. While opioid painkiller prescriptions are becoming more closely regulated, cases of overdose and addiction are still increasing, especially among younger people. Many of the early cases of addiction were middle-aged people who became addicted to painkillers they had been prescribed or received from friends and family members with prescriptions. Today, young people are often introduced to prescription opioid drugs in those ways, but move on to heroin or illicit synthetic opioids that are cheaper and easier to come by. Beyond tighter regulation of opioid painkillers, what can we do to reverse the growing rates of addiction and overdose? A drug called naloxone is currently our best defense against overdose. Naloxone binds to opioid receptors but doesn't activate them. It blocks other opioids from binding to the receptors and even knocks them off the receptors to reverse an overdose. Opioid addiction is rarely a standalone illness. Frequently, people with opioid dependence are also struggling with a mental health condition. There are both inpatient and outpatient programs that combine medication, health services, and psychotherapy. But many of these programs are very expensive, and the more affordable options can have long waiting lists. They also often require complete detoxification from opioids before beginning treatment. Both the withdrawal period and the common months-long stay in a facility can be impossible for people who risk losing jobs and housing in that time frame. Opioid maintenance programs aim to address some of these obstacles and eliminate opioid abuse using a combination of medication and behavior therapy. These programs avoid withdrawal symptoms with drugs that bind to opioid receptors but don't have the psychoactive effects of painkillers, heroin, and other commonly abused opioids. Methadone and buprenorphine are the primary opioid maintenance drugs available today. There's still a long way to go with combating opioid addiction, but there are great resources for making sense of the treatment options.
Thanks. So I hope you found that a little bit useful visually. Yeah. So opioids are drugs that bind to opioid receptors. Opioid receptors are present in many parts of the body, not just the central nervous system. So while they can reduce pain, they can also cause nausea, constipation, cough depression. Often opioids are used to control uncontrollable cough. They cause sedation, euphoria, of course, and at toxic doses, respiratory depression, which leads to cardiac arrest and death. That's how they kill. We're not going to watch that. Okay, let's talk about opioid use disorder. So Diagnostic and Statistical Manual of Mental Disorders, the DSM, is the authoritative guide to the diagnosis of mental disorders. It provides for the descriptions, symptoms, and other criteria for a clinician to arrive at a diagnosis, okay? So these are the criteria. First one is that the opioids are often taken in larger amounts than the person intended over time. The person expresses a persistent desire to cut down or control their use of the opioids. They expend a great deal of energy, effort, and resources to obtain their drugs. They express a craving or strong desire to use them when they're not in possession of them. They keep using them despite knowing that it's causing personal problems in their lives. Things that they used to do that provided them with joy, recreational activities, social activities, interactions are curtailed because of their drug use. They continue using despite knowing that there are physical hazards present, which could include, of course, unsavory or dangerous people, as well as dirty needles and other risks to their health, physical health. They continue using despite knowing that physical or psychological problems are being caused by their drug use. And of course, these two physiological phenomena, tolerance and withdrawal, which Mike mentioned in the video. So if a person displays or demonstrates 2 to 3 of these criteria, that's considered a mild form of OUD, 4 to 5 is moderate, and if they're 6 or more, it's a severe form of OUD, and we manage them a little bit differently. Okay, what is stigma? I don't know if stigma training is part of your official curriculum now. Oh, thank God. I don't know what year they started it, but thank God that it is. I've spoken to numerous health sciences faculties over the years and very recently as well, and stigma training is not part of their curriculum. I'm so heartened to hear that it is. So let's review quickly. Stigma, of course, is a negative or discriminatory attitude towards a person, typically based on some characteristic that they possess, what they look like, how they behave, things they say. And probably, I say possibly here, but stigma, which is related to the concepts of shame, disgust, and guilt, probably developed as a useful feature in early human societies in order to curtail risks both in group and out of group. Okay, so an early human society would have known that the appearance of a group of people who don't look like them might pose some kind of risk of invasion or pathology. We know that 1/3 of the population of the Americas was wiped out by smallpox from the advent of European colonization. It's not unlikely that this knowledge is well defined within our historical understanding. Also, within a group, it helps to maintain social cohesion by discouraging unwanted behaviors that might undermine the cohesiveness of a particular society. So guilt, shame, stigma may have been useful tools in the past, but we know that stigma and shame can last a very long time. Furthermore, they can be used to manipulate and control others, and they can make the person's symptoms worse and decrease the likelihood that they're going to seek help. All of those are bad things, okay? Also, stigma ignores the very many social determinants of health, the person's access to education, access to employment, access to nutritious food, et cetera, et cetera. All of these things that are outside potentially of the person's control that have a potentially great impact on their health, okay, including their risk of developing OUD. So precisely how much responsibility, I mean, I believe in personal responsibility, okay, for adults, I do. Precisely how much responsibility you want to assign to a person who is not necessarily, prefrontal cortically able to override the impulse to continue using because their body is going to go through a very debilitating withdrawal. I think we have to ask ourselves that question. Coming back here, okay, familiar with Prochaska and Di Clemente? This is the trans-theoretical model of change. We hear a lot these days, particularly from politicians, speaking points are very simple and facile when they say, we just need to give them treatment. Let's develop treatment, let's push treatment. This treatment is the answer. Yes, treatment is an answer. It's one of the 4 pillars of any good drug strategy. However, a person has to be ready to undertake treatment. And this is a prevailing psychological theory. We've used it for many years, understanding that a person who is in a pre-contemplation stage of change is, and you've tried to force treatment upon them, the likelihood that they're going to fail is much higher. So it's appropriate to offer treatment to a person, but only to undertake a treatment course when that person is prepared to actually make those changes in their life. So at any point after the action, or any point along this spectrum, this continuum, a person can relapse, okay? And they might have to start over again. They might say, okay, I tried it once, it didn't work, I'm just gonna go back to using. And while that person is using, we don't want them to die. So we wanna make sure that they remain safe, and this is where harm reduction comes in, okay? So, very important concept to understand. This is why treatment isn't the only answer. And it must be used at the appropriate time, and that's based on the assessment of skilled clinicians like yourselves, okay? Also, you must be familiar with Maslow's hierarchy of needs. Basically states that until foundational needs are met, these physiological needs, air, water, food, shelter, sleep, clothing, personal safety, okay? Until those things are satisfied, a person is not going to be able to aspire to self-actualization. So how reasonable is it that we're going to force treatment upon a person who is unhoused, who's not sure about where their next meal is going to come from, not sure if they're going to be assaulted for whatever small possessions that they have? Okay, so let's not be simplistic in our thinking. Stigma also ignores these very important concepts that we like to think we aspire to as a society: forgiveness, generosity, empathy, hope, right? Nobody chooses to become dependent on a substance. Nobody, I promise you, chooses to become dependent on a substance or a behavior. Most people get their first exposure to an opioid through a legal prescription, and healthcare providers like you and I are not immune to stigmatizing attitudes towards patients or other members of the public. It's very well established. We conducted a study, we had a grad student from McMaster, contacted all the pharmacies in Hamilton and asked them if they carried naloxone and offered it to their patients and their community. And if they didn't, why they didn't. And we learned a lot. Okay, we learned clearly pharmacists can harbor stigmatizing attitudes. You know, we have a polarized political environment, and it's becoming increasingly polarized over time. And I think it's partly because it's hard to think about the complexity and details and try to understand them when we have so much else that's pulling at our thought processes. So it's easy just to say, okay, now I'm just going to resolve to pick this. But that's clearly not the way that we're going to do the best for ourselves and for our patients. So check your stigma. I'm not going to run this video in the interest of time. I'll just let you know that the city of Hamilton engaged a drug strategy in 2018. I was the pharmacist representative on that strategy. And in late 2018, we tabled a report as well as a number of action steps. Basically, foundationally, there were the 4 pillars: harm reduction, prevention, treatment, social justice. And I work on the harm reduction working group, and the city produced a number of videos called, oh, what the hell, let's mind the COVID beard, okay?
My name is Faisal Khawaja. I'm a pharmacist and the operations manager at Marchese Healthcare. I'm also the lead naloxone trainer. I've definitely seen people with conditions like diabetes or cancer are definitely treated differently than people who have mental health disorders. And substance use disorder being in the spectrum of mental health, there is definitely a stigma attached to mental health disorders on the part of healthcare providers. We have this paternalistic approach where we think, like we would treat our children, you know, we teach them. You've been given the information, you've been given the knowledge by me, or by other people, or by your teachers, or by society. You should know better. There's obviously still work to be done, even amongst the people who should know. One of those kinds of things that you can do is to learn about naloxone and get trained on naloxone and be prepared with naloxone in the event that you're in a position to help somebody with an opioid overdose. It's really not that difficult to see the impact of stigma on people's lives in many different areas. You only have to walk around or drive around the city and see how people who are perhaps homeless or otherwise affected by various economic challenges, how they're treated by different people on the street or in their cars or what have you. Some people have a tendency to lead with compassion, and you know, they'll reach out, they'll talk to these individuals and engage with them with an understanding that their essential humanity is the same as their own. Other people, not so much. So if people have the idea that it is a street person that uses heroin and they've sort of brought this upon themselves based on the poor decisions that they've made, that's completely wrong. Anyone from any walk of life, any socioeconomic stratus can be affected and is affected by substance use disorder, and right now opioids being a particularly serious crisis. So I want people to understand that. It could be someone that you know, someone that you work with, someone that you love that has the potential to be affected by this. So if you bear that stigma, it's going to be really difficult for you. If you have that mindset, it's going to be really difficult for you to relate to that person and to help that person that you love potentially to work out a way to address, to ameliorate, to make better, to get past this particular problem that they're having. So if you really care about the people that are around you, then you should care about this issue. If you have a connection, if you have a child, you understand that you would do anything for them and that they are the most important thing in your life. You understand in that moment that you would not hold something back from them or deprive them of something that potentially could help them or save their life, and the judgment goes away. And it's probably the most powerful way to address this problem is to meet people with lived experience, to talk to people with lived experience. Harm reduction for me is so critical because it tells us that there's hope. We believe every individual has a future. And if we believe that every individual has a future, then we have to start by making sure that they're around to see that future.
that last person that you saw in that video was my friend, Rebecca Morris Miller. She was the founder of Grenfell Ministries, which founded the National Overdose Response Program. So she was a person that suffered from opioid use disorder. She'd been clean many years. She was experienced with the criminal justice system. And on October 31st, a year and a half ago, she was at a conference in Toronto, and in a momentary sort of lapse of judgment, accidentally overdosed on fentanyl that she bought in Toronto. So we all have reasons why we do things and why we decide to, spend our energy and some time doing different activities. So she's my main reason why I continue to do this. I'll talk to anyone, I'll present for anybody. Find the person that matters in your life, that whether they have a substance use disorder or an addiction, we use these terms interchangeably, whether they have a problem like that or not, it's important to recognize that there's potential for any of us to find ourselves in that situation. And you may not think it, but it can absolutely happen. And, she had a very good upbringing. She had two parents that were both social workers with master's degrees. And she's very well spoken, very thoughtful, very caring, compassionate. And just through whatever series of circumstances, she found herself in that situation. Okay. And, just think about the fact that within 1 or 2 degrees of separation, you may know somebody that's personally affected by this crisis. And hopefully you'll carry the weight of that in your understanding, and as you move forward, that it can happen to anyone. So there's a series of videos. I encourage you to look them up on YouTube. It's #SeeThePerson, and they're very well done, and I think they're very useful. Let's talk about some different types of opioids. I'm going to mention morphine here. So Mike in his video mentioned morphine. It's the opioid with which we have the greatest experience historically, right? So it's found in ancient materia medica. And so therefore we kind of compare all other opioids potency-wise and effectiveness-wise to morphine. So you can see the hydrocodone and tramadol and codeine are considered weak opioids because they fall below on that ladder. Codeine is about 15% the strength of morphine. Oxycodone and heroin are both about 50% stronger, so 1.5 times the strength of morphine, so fairly powerful. Both of those happen to be very lipophilic or fat soluble, which accelerates the transfer from the bloodstream across the blood-brain barrier into the brain, which is why they are preferred for injection drug use. Hydromorphone is 5 times stronger than morphine, 500%. It's dilaudid, right? It's the opioid that we use most often when we're talking about safer supply. So people who are using drugs, so they're not in treatment, right? But we don't want them to use the street supply, so we prescribe them a backbone of long-acting morphine or methadone sometimes, and then they're allowed to take home, which I witnessed at the pharmacy, and then they can take home a small quantity of hydromorphone that they may use via injection, okay? But at least it's of a known potency and a known origin, so they're far, far less likely to experience a poisoning event because of that safer supply. It's a concept. Methadone. So methadone is more powerful than hydromorphone, but I put an asterisk beside it because one of the unique aspects of methadone is that it has a very long half-life. The half-life is the amount of time it takes for your body to get rid of half of the dose that you took. So whereas morphine and hydromorphone, codeine, half-life is typically between 4 and 6 hours, so you have to redose on that interval. Methadone's half-life is between 24 and 36 hours. So, which allows it to be very useful in a treatment situation because I have to witness the person taking that dose. And if they had to come back every 4 hours or every 6 hours, they'd never leave the pharmacy, right? They can come in for their methadone, I witness them, I make sure they're not intoxicated, right? I make sure that they understand the dose that they're receiving. So I screen for a bunch of things, and then when I feel comfortable, I'll release the dose, watch them take it, and then they can go to school, hold down a job, look after their housing situation, whatever they need to do, without having to be bound to coming back all the time. So methadone is very useful because of its long-acting nature. Buprenorphine, which Mike mentioned, is found in combination with naloxone, paradoxically, you might think. But it's combined with naloxone in order that if a person decides to dissolve it and inject it, right, even though the pharmacist has witnessed them dissolving the tablet under their tongue, sometimes people are very sneaky. They'll cheek it, okay, or find some other way to divert it in their mouth. And then they'll take it home. Even with methadone, sometimes they would put cotton in a little pocket back here, and they put the methadone there, and then they go and squeeze it out, inject it or sell it or whatever. People do all kinds of things, okay? But the naloxone is present to oppose the effect if it gets injected. So again, diminishes the likelihood of a poisoning, right? Buprenorphine is also now available in a long-acting injection. So instead of coming once a day, they can come once a month. Physician has to do that injection unless it's a medical directive or allowing someone else to do it. But now the person can go 1 month in between their doses, okay? And it's emerging as a very, very useful treatment. Of course, it doesn't have the daily invigilation that a pharmacist or a clinician, doctor or nurse would have, and following up with the patient, making sure you have a touch point, making sure that they seem to be psychologically stable, these other types of things that you can intervene with if you're seeing them every day. So we reserve that for people who either can't come every day, or we feel that they would be okay with respect to these other aspects, that they can come once a month. Fentanyl, it's in big letters and it's near the top of the chart for a reason. It's 50 times to 100 times more powerful than morphine. So 5,000 to 10,000% more powerful than morphine. Fentanyl in its crystalline form, the amount that is required to cause a lethal dose in a human is equivalent to a couple of grains of salt. Okay, it is extremely potent. Carfentanil is 50 to 100 times more potent than fentanyl. So carfentanil is only ever intended to be an large animal tranquilizer as for veterinary use, but somehow naturally it's found its way into the drug supply too. So extremely powerful. There's a host of other fentanyl analogs, nitazines, and a very heterogeneous concoction of opioid substances that are in the street supply. I won't go into sort of where it's originating, but you need to know that unlike heroin, which if you watch the movies, you know, they've got these big bags because the relative potency to fentanyl is so low that you require a truck or a boat or a plane or something in order to transport large quantity. Fentanyl, you can put in an envelope and mail it anywhere. Canada Post is not screening every 30-gram envelope that comes through the mail. So the likelihood that we're going to stop importation and distribution, in my view, is extremely unlikely. Therefore, we must focus on these other 4 pillars: prevention, harm reduction, treatment, and social justice. Okay, so those are some opioids. And you can see starting in 2015, 2016, fentanyl starts to break away from the pack in terms of being the opioid found present at the time of death. And it's continued to be the most common, probably 75% of opioid poisoning deaths involve fentanyl, but that still leaves 25% of a big number caused by other opioids, including prescription opioids, okay? So we take nothing for granted. So it's a lot of negativity and doom and gloom. So I'd like to talk about a couple of other concepts, not probably talked about in a medical lecture so much. We're going to talk about society, suffering, and resilience. We're going to talk about fragmentation, trauma, attachment theory, despair, and the impact of the pandemic. So this is Dr. Bruce Alexander, psychologist in the West Coast of Canada, BC. He wrote this book called The Globalization of Addiction, a study in poverty of the spirit in 1985. So that's a long time ago. And in the video, Mike mentioned that the current crisis started in the 80s and the 90s. Okay, so I started my pharmacy career in 1993. OxyContin didn't start hitting the waves till like the early 2000s. So Dr. Alexander wrote this book in 1985, very early days in the current wave of the opioid crisis. So he points out that there are millions of prescriptions written for opioids every single year. These stats, 2 million people, or 1 in 7, they're not his stats. This is from Ontario Public Information. In 2015, 2016, in Ontario alone, a single province, 2 million people received prescriptions. That's 1 out of every 7 people received a prescription for an opioid medication, representing 9 million prescriptions filled in Ontario alone in 1 year. Yet, less than 10% of those people reported problematic use. So this means, 1, it's not just the drug that causes dependence or addiction or use disorder. And in fact, it's not even primarily the drug that contributes to the problem. So what is it actually that causes dependence? Dr. Alexander believes that most serious addictions don't involve drugs or alcohol. That addiction is a social problem resulting from the increasing fragmentation of a society. If you look at our society today, particularly in the political realm, I think it would be hard to argue against the idea that we're becoming more fragmented over time and not more cohesive. Okay? So he says that addiction is a way of adapting to extreme social dislocation. Especially since the advent of the internet and social media, we know this is happening. We see rates of anxiety and depression, particularly amongst young people, rising at historical rates. It's because they're not connected to one another the way that they were when we had organic relationships on the playground. Addiction is not a disease nor a moral error, sort of the DSM notwithstanding, and it cannot be corrected by punishment or education simply. Okay, and there are addictions of all kinds. He says most serious addictions don't involve drugs or alcohol. What other kinds of addictions are there? Phone addiction, screen addiction, okay? In the video, Mike mentioned that, dopamine gives us that good feeling. I might take issue with that. It's more complex than that. Dopamine is actually more likely to be the reinforcing neurotransmitter, okay? But the experience of euphoria is more related to basal ganglia. It's a complex mechanism, okay? But dopamine reinforces when we do things that make us feel good, okay? It'll reinforce that. So, yes, screens, gambling, gaming, which used to be called gambling, okay? Gaming, video gaming, right? Whole generation. Video games, they're bigger than Hollywood and the music industry combined, right? We don't appreciate how potentially dangerous these things are. Obviously, you can tell that I'm a father. And did you notice I'm wearing the same shirt that I was in the video? I just realized that I have more than one shirt, I promise. Shopping. Okay, food. All of these things, sex, all of these things that make us feel good in the moment, that are a way of correcting or dealing with this fragmentation, this loss, this disconnection. Okay, this is Gabo Mate. Anyone familiar with him? Lots of nodding heads. So he's a medical doctor, he's a physician, working also in BC, okay? He is a Holocaust survivor from Hungary. And it is his personal experience that trauma, which is especially that which is experienced in childhood, leads to long-lasting effects. So, in his own personal experience, he knows that he did not experience joy for many, many years because of his experience when he was a child. And we know that there are children like that experiencing neglect, abuse, okay, in our society here today. Lots of other circumstances that can lead to this suppression of the release of those happy feeling substances. And so when that child grows up and eventually does discover something that makes them feel good, they're going to gravitate to that activity. Okay, and that's the foundation of dependence. So trauma is Dr. Abulmate's particular area of expertise. And so now we have a whole realm of trauma-informed care and focus. And this is Dr. Gordon Neufeld. He's a developmental psychologist, also from BC. You can see a theme here, okay? I've just selected these 3 researchers, for sure. Okay, Vancouver, everyone's familiar with Vancouver and the drug crisis there. Anyone visited Vancouver before? Have you been to East Hastings Street? I have. Okay. And I grew up in what I considered before that to be sort of a ghetto neighborhood in Rexdale in Toronto. Okay. And I thought it was pretty rough there. I never have seen, no, not never. The only more dire circumstances I've ever seen is in my own home country of Pakistan. When I got married there many years ago, we have a tradition that, you sacrifice a goat or a lamb and you distribute the meat amongst the poor as a sort of offering or blessing. And the place where we went to distribute the meat was the most grindingly impoverished place I've ever seen on earth. East Hastings was only second to that. Okay, so shocking, but maybe not so shocking why all these researchers are experts in working in British Columbia. So Dr. Gordon Neufeld, developmental psychologist, which means he works with children. And he's a world expert on attachment theory. Attachment theory basically says that failure of a child to properly attach to the adults that are responsible for them can lead to a lifelong impairment in their ability to form healthy relationships. Okay, so attached children growing to strong, stable adults. I think we are seeing fewer strong, stable adults than we have in my lifetime and in the historical understanding that I have of generations in the recent past. What are we willing to do to ensure that our children are properly attached to the adults that are responsible for them? Whatever we're doing, we need to look carefully at it because we're doing some things really wrong. Okay. And as much as we don't like to admit it or confront it, we're doing some things really wrong. Okay, so again, all of those psychological considerations should give us some thought. Let's talk about chronic pain, okay, as a contributor to the opioid crisis. Chronic pain is an enormous economic burden around the world. 30% of people, 25 to 30% of the people in this room, maybe you're not a representative sample, but 25 to 30% of the people in this room will experience chronic pain in their lifetimes. Chronic pain is also very highly stigmatized. No one wants to hear you whine about your pain, right? Shut up. I got my own problems. And it's notoriously badly managed by the medical community. Me. Okay. Physical activity is the key. It's the cornerstone of prevention and management of chronic pain. Unfortunately, wealthier countries, more affluent countries, more developed countries become less active the more affluent they become. And what they expect is for you to write me a prescription. I want to get in, I want to get out, and I want a quick fix. And we know that the evidence supporting use of opioids for chronic pain is extremely poor. Okay, so the use of opioids for chronic pain should be highly discouraged. I belong to the University Health Network ECHO Chronic Pain and Opioid Stewardship group. And it's maybe not shocking the number of people that are prescribed opioids for chronic pain. Okay, and they don't work. All medications have limitations. We had hoped, some people had hoped that when medical cannabis was made available in Canada, that we would see the end of pain, end of chronic pain. So don't get me wrong, there's lots of good evidence. Even before it was legalized in Canada, there were like 10,000 studies, okay, on the main derivatives, let's say, of cannabis. And they found that it is effective for certain conditions, including certain types of pain, but the effect is very modest. So it's not a cure-all. It's not a single solution. Can be useful, but in complement with other treatments and other management programs. Pharmacological approaches should be the last consideration. Okay, coming from a pharmacist. So do we actually have an opioid crisis? Or do we have what I believe is a crisis of pain and suffering, a crisis of meaning and connection, loss of connection, loneliness? We have 8 billion people on the planet. We live in densely packed cities and we're lonelier than we've ever been. How? And all that doom and gloom, like I said, I must end this section by talking about resilience. Physical trauma and abuse are absolutely real. They can be very long lasting, and suffering is also real, but it's not a death sentence. Human resilience is real. We see children can be very resilient given the opportunity. Okay, so it's never too late and it's never too early to start thinking about making corrective steps. There's always hope for recovery in a future. Okay, 4 pillars approach. I'm going to speed through. So, founded in Europe, Switzerland adopted in 1994, Vancouver in 2001, Hamilton 2018. Like I mentioned, it is gaining support across the world. Raise your hand if you've heard about the Portuguese experience. Okay, a couple people. So famously, Portugal in 2001, they were experiencing massive problems. They had the highest rate of novel HIV diagnosis from injection drug use. Their incarceration rates were high. They were spending tons of money and they were going nowhere, just like every approach that we've ever taken here. Just say no to drugs, the war on drugs, all of these failed mechanisms, okay? So they famously reversed all that and decriminalized the possession of all illegal drugs with some caveats, okay? They took the money that they were spending on policing and the courts, and they didn't just absorb it, they reinvested it into education, harm reduction, prevention, employment. So guess what? When people are educated and gainfully employed and stable in their homes and not afraid that they're going to be thrown in jail, they don't use drugs. Okay? So the Portuguese drug policy model prioritized public health over public order. They decriminalized possession and use of all illegal drugs, and they redirected those funds. Housing. Okay. Drug-related deaths fell and have remained below the EU average ever since. The proportion of the prison population sentenced for drug offenses fell from 40% to 15%. That's obvious, they're not prosecuting them. Okay. The rates of drug use remain consistently below the EU average ever since 2001. And they went from representing over 50% of yearly HIV diagnosis from injection drug use to 1.7%. Okay. And we know that these communicable diseases like HIV not only affect that person, they have a domino effect. It's a sexually transmitted infection. Okay. So they will affect a disproportionate number of people in the population and wreak havoc on their lives, the lives of the people around them, and the costs incurred by the society that has to then deal with them. Okay. Unfortunately, it appears that a punitive approach is starting to rear its ugly head in Portugal over the last 10 years. And this is the pendulum nature of politics, I guess. It's unfortunate. Okay, so these are 4 pillars: prevention, harm reduction, social justice law. In some circles, it's called law enforcement and treatment. Prevention, of course, we don't want people to use in the first place. How do we do that? We make sure they're stable, they have good access, good education, housing, food. They feel secure, right? They feel loved, connected. Harm reduction, we want to make sure that we respect the rights of people to use drugs if that's the stage of change that they're at. That's a tough one for a lot of people to get over, right? The answer should obviously be, don't use. They're not at the right stage of readiness, and we want to envelop them with a wraparound care, right? For them to know they have access to this service, they have access to social work, they have access to psychology if they need it, right? They have access to housing supports. Make sure they know that they have these things accessible, increases the likelihood that they'll actually reach out. If they don't, if they're in a vacuum, how likely are they that they're going to try and tackle it? We want to reduce morbidity and mortality. We want to be non-judgmental. Social justice, very simply, we want our laws to reflect our values and our beliefs. If we believe that a person who no longer has a meaningful ability to control their actions related to their substance use or their addiction of whatever kind it is, okay? If we believe that they're going to go through a debilitating withdrawal, and that's what's their primary motivation to continue using. Most people can't even get high anymore. They're trying to avoid going through withdrawal. Okay. So how much responsibility are we going to put on that person and just tell them not to use? and treatment. Methadone, buprenorphine, naloxone, buprenorphine injection. And that's 50% of the solution. The other 50% is behavioral therapy, okay? Very often I see this one. I'm not so confident that I see the other. This is easy. This is hard, right? So I see tons of, personal opinion, I see lots of mills. People go in, they get their medication, and they're like this, right? They're not getting the psychological support that they need. It's very, very important. So again, as a pharmacist, I can appreciate the importance of proper therapy. Okay, we're gonna just jump through this. Naloxone time. Ooh, okay, I'm going over time, sorry. Right, what is naloxone? We know naloxone is an antidote. It's an antagonist to opioids. In the 60+ years that naloxone has been available to us, you might think it's only been a short time, okay? More than 60 years. Developed by a physician. His son, tragically, ironically, died of an opioid poisoning. In those 60 years, never once been found to do anything other than antagonize the presence and action of opioids at opioid receptors in the body. Okay, it's extremely safe to use. Also, there's never been a single credible case report of an IgE-mediated allergic reaction to naloxone in the medical literature. You can feel safe if you have not 100% perfectly assessed the person that you're going to give naloxone to, that you're not going to hurt them. Okay, if they're not poisoned by opiates, maybe they had, I don't know, cardiac arrest, or who knows, right? And you give them naloxone, nothing bad is going to happen to that person. You feel extremely confident about that. Well, usually I mention this because members of the lay public are protected by the Good Samaritan Act, and medical professionals who are not in their workplace. So if you're not at the hospital, and you're at downtown Hamilton, and you respond to somebody having an opioid poisoning, you're covered by the Good Samaritan Act. In the hospital, you have to have insurance. Okay. So it protects rescuers from legal liability in the event that they accidentally harm the person that they're sincerely trying to save in a medical emergency. The Good Samaritan Drug Overdose Act was enacted in 2017 federally, right? The 2001 Act is provincial. Federal Act because it was felt that people were hesitating to call for help, and hence increasing the likelihood that the person would die because they were afraid that they themselves would get busted if they called the police or called 911. So now people are protected from prosecution if they're in simple possession. Okay, if they're actively trafficking, they got a car full of drugs, they're not protected. Okay, but then if simple possession of illegal drugs, they're protected from prosecution. And if they're in breach of their parole or probation conditions, they're also protected. That's the Samaritan Drug Overdose Act. Okay, tell me if you have had first response training, first aid training, CPR training. Raise your hand if you haven't. Okay, everyone has, yay, save time. So we know ABCs, right? First thing you do is you assess the scene for dangers, et cetera, et cetera. If you have advanced training, this training is not meant to replace that. We're going to launch into the 5 steps now. We finally made it. We're on the home stretch. Okay. So there's 5 steps to save a life. Oh, I didn't ask the people that are watching remotely, viewing remotely. I'm just going to assume that you all have first response training too. Okay. If you don't, you can call me and we can figure something out. Oh, beautiful. Good. I also hope I didn't insult the intelligence of people who have like an undergrad biochemistry degree and you're watching, you know, these visualizations of receptors, etc. So, okay, so the first step in the Ontario protocol. The BC protocol and different protocols vary a little bit in their acronyms and how they go about it, but the major steps are the same. So the first thing we want to do in step 1 is to assess whether the person is responsive to our stimulation. So it's SSSS, shout, shake, stimulate, slap, okay? So you encounter someone that you're concerned about. It may be at a party, maybe at a bar, maybe at a restaurant, could be anywhere. You might be walking downtown Hamilton and there's a person asleep in the doorway of a business. I never assume that a person is asleep in a doorway. First of all, it's an unnatural condition to be in. And it's a sad statement that we've become so accustomed to seeing it that we think it's okay or that it's normal. Every person I walk by, I'll walk up and say, hey, are you okay? If they tell me to screw off, nice words, I know they're okay, right? But if they don't respond, I'm gonna move up a little closer. Hey, buddy, my name is Faisal, are you okay? No response. Hey, wake up. Why do you wake up? Can I help you? Are you okay? They're not waking up, then you have a medical emergency, right? The person is unresponsive, and you have implied consent to proceed with the next steps. If they tell you, I'm okay, leave me alone, obviously they're okay. If they, that's not really responsive. Okay? And if they do tell you, leave me alone, but you're still concerned about them, you can back off. Can't do anything to them or for them, but you don't have to leave. Right? If you're really concerned about them, you can stick around to see it through to whatever you might hope to be able to determine for them. Okay, so try and stimulate the person, ask for consent. If they're unresponsive, consent is implied. It says to put on your gloves. Okay, before you touch the person, ideally, there's a pair of gloves. I'm going to show you the fits. I have bad news for you. So normally, I've lost count of how many sessions I've done training like this. And normally I'll bring naloxone kits for everybody so that you have your own personal supply of naloxone kits to take home. On February the 9th, so just a couple of weeks ago, the Ministry of Health announced that pharmacists can no longer provide naloxone kits outside of a pharmacy. So you have to come to the pharmacy to pick them up. We're not allowed to train more than one person at a time. So if you come in with your significant other, I have to tell your significant other to sit down for 15 minutes while I train you, and then I can train them. This is government, okay? And a bunch of other changes that, in my view, are intentionally designed to raise the barrier to access to this life-saving treatment. And we're going to see more deaths. Unfortunately, politics is not something that we can avoid. But you can get your kits when you have your training certificate that you'll get via email. Come into the pharmacy at any time. We're open 7 days a week, okay? On Sundays and stat holidays, we're open 10 to 2. So you come in the middle of the day, show your training certificate. I will train me at MAC, 5th of March, and then we'll just give you your kits. Okay, and they can have them. So there's a pair of gloves. Actually, there's 3 gloves in here. Okay, there's 3 gloves. There's a CPR face shield with a one-way valve. There's 2 alcohol swabs in the injectable format, which you won't need, but the ministry makes us put them in. There's 2 vial doses of naloxone injection and 2 safety syringes, sterile syringes. Good idea to put your gloves on now. If you forget at this stage, it's probably not a big deal. But these are the signs that we're going to look for. Step 2, by the way, this is called 911. Okay. I'm just going to tell you what signs to look for that could indicate an opioid poisoning. So remember, opioids cause respiratory depression. The person's breathing is going to be shallower, slower, more labored. They're struggling to breathe. Okay. They might sound like they're breathing because it sounds like they're choking or gurgling or snoring, especially snoring. Okay. It sounds like they're breathing, but they're not breathing normally. They're struggling to breathe. This is sign number 1. Because of this, they're going to be hypoxic. Okay. So their skin tone is going to be paler than usual. Their light-skinned individual might appear more gray or green. Okay. If they're darker skinned, might appear more ashen in tone. If you look at their fingers, fingernails, lips, might appear blue. Okay. Sign number 3, their skin might be cold or clammy. If you put the back of your hand on their forehead, be diaphoretic. Okay, sweaty. Their body's probably very limp, as opposed to someone who's having a grand mal seizure. Might be rigid. Okay, so limp, crumpled body, often in the fetal position, very common. And if you get a look at their pupils, they might be tiny, constricted pupils, or pinpoint pupils that are a sign of opioid use. There may be drug paraphernalia nearby. There may be vomit present. Okay, you have to notice about one of these signs to consider that the person could be having an opioid poisoning. So it's not necessary to check for a pulse in this protocol. Okay, again, if you have advanced training, by all means use that. Okay, defibrillator nearby, by all means. Okay, but in this protocol, it's not necessary to check for a pulse. Step 2 is to call 911, of course, because we only have, if we have naloxone with us, we have a limited number of doses. It takes often 6 to 8 to 10 doses to reverse a poisoning from fentanyl. Okay, there's 2 doses in each kit. So make sure that the paramedics are on their way. They've got more naloxone. They've got oxygen, which the person vitally needs. They can transport that person to the hospital. Okay, they've got advanced training. make sure they're on their way with zero delay, which is why we call them before we give naloxone. Okay? Who has not handled a needle and syringe before? Oh, yeah, good. Okay. So, I'm going to demonstrate for you. I didn't bring enough for everyone to try it if they wanted to handle needles. I'm not sure if you had permission to do that anyways. Maybe in a future iteration of this lecture, I'll bring plenty of supply and we can do that again. But I'll demonstrate for you exactly how to drop a vial of medicine and then how to inject it. Okay. So as I mentioned, oh, by the way, why am I bothering to talk about injector? Intranasal is available. There's no needle. It's easier to use, obviously, no risk of needle stick injury. Any thoughts? When we give something by injection or parenterally, it's 100% bioavailable, right? We know predictably how much that person got. When we give something via intranasal administration, the absorption is much more variable, okay? Based on the presence of nasal hair. And if you've seen some of the people in the unhoused community, there's plenty of nasal hair, okay? Mucus, vomit in the nasal passage. Person may be a nasal drug user. They may have a sinus infection. Infection is very common. So their absorption rate or level of intranasal naloxone can be much more variable, okay? When you give something via injection, it's much more predictable, right? That's reason one why you might. I'm not here to tell you which one to use. Whatever you're comfortable with, you use that, okay? Also, they have to actually put 10 times the amount of naloxone in one dose of intranasal spray to get the same effect on paper as a single vial of injectable. That reflects the variability of the absorption. But if a person gets a very large level, a high level of absorption, they can actually experience what's called an acute opioid withdrawal syndrome, AOWS. Generally speaking, opioid withdrawal is not life-threatening, okay? But depending on the fragility of the person, the frailty of the person, a very acute opioid withdrawal can be life-threatening. It's rare, okay? So I'm not going to overstate the potential. But if it was an infant or a pregnant woman that is experiencing poisoning, I would prefer to give the injectable. For me, it's gentler, more predictable, more reliable. Again, if you only have one of them, you use that, right? Or whatever you're comfortable with. But I'm comfortable handling needle and syringe, so for me, it's easy. Also, this isn't a glass vial, and in Canada, in February, usually, if you keep naloxone in your car, it will freeze. Okay? Maybe not this winter, but it will freeze. And if you keep naloxone in your car all the time, like I do, because I know I've got naloxone within a couple minutes reach, the only one you can keep in your car is the injectable form. It's been tested, and it's stable after freeze thaw, and it's stable after exposure temperatures as high as 80 degrees Celsius. Cool it to a comfortable temperature, you can inject, it's still stable. University of Waterloo Pharmacy School did this study, okay? The intranasal has not even been tested for that possibility. So, many other reasons, okay? This is less expensive. These are public dollars, our tax dollars, less expensive because it's off patent, all right? Okay, enough said, let's do it. So again, if you remember to put your gloves on at this stage, it's a good idea. I won't just because. First thing you want to do is take out one of the vials. Okay, there's two vials like I mentioned. Pop off the cap. I'm going to come up front here. Okay. You're going to pop off the cap of your vial. Then you're going to take one of the safety syringes, peel it open, and take it out. Camera, people can see me on. Oh, hello, camera.
Yeah.
Okay, you won't be able to see this close up, but fortunately for you, on our YouTube channel, you can watch me go through this process much more close up. Okay, so Arcadian Pharmacy, Naloxone, you can look it up. All right, we've got our vial. We peeled open our package. We're going to grab the barrel in our non-dominant hand. We're just going to unstick the plunger. When it comes from the factory, it's a little bit sticky. Okay, just unstick that. Draw 1 cc of air into your syringe. Transfer to your dominant hand. Holding it like a dart, as if you're at the pub. Okay? Take off the cap. Holding the vial neck between your thumb and forefinger. In fact, you can put all your other fingers on it. If your adrenaline is pumping, okay, and you're shaking, and you're afraid you're going to stick yourself, you can rest one hand against the other Now you have one unit, much more stable, and you can easily watch that needle tip go into the middle of the vial. Okay, just like that. You don't go in very far, you're just going just past the septum. If you push it in too far, when we invert it like this, the needle tip is going to be in the air pocket. Okay, so we want to get the needle tip as low as we can get it while still being inside. Grab the barrel non-dominant, plunger. Now our hands are nowhere near the needle tip. Okay, so this technique is very important in minimizing your chance of getting stuck. If you poke yourself by accident, the needle is sterile, the naloxone is sterile, you're not consuming opioids, nothing bad is going to happen to you if you inject yourself with naloxone, okay? But you can't use that needle on a person, right? Okay, it took 3 seconds to get that dose out. Now I'm very deliberately going to separate those two, holding it vertically again, just going to push up because there's a large air pocket there, push it up until I see liquid coming out. And I'm going to look at the bottom of the barrel here and see if there's large bubbles. If there's large bubbles, we can inflict them. If they're tiny bubbles, because we're doing an IM injection, okay, intramuscular, we're probably not going to bother with that. If there's little champagne bubbles, we're not going to worry about it. But if they're big, we're going to flick them, pull down to leach those little bubbles, and then push up again until we have no more air. Okay. Then we're going to proceed directly to giving the injection. I will put it down, but you will not put it down. I'm going to demonstrate to you how to locate or landmark the two muscles that you might consider. The two that we recommend are the deltoid muscle and the vastus lateralis, okay? Not the gluteal muscles, just because the thickness of the subacute space is too variable, deltoid or thigh, okay? So, there's different ways to landmark the deltoid muscle. I'll teach you a couple. The one I teach most often is take your index finger, follow your clavicle to the end of the chromium process, okay? You should be able to feel the tip of that bone. Your finger falls into the groove. Then rest your next two fingers aside. The third finger represents the upper range, maybe just below that, of the heart or the center of that triangle, deltoid being a triangle, of course, right? If the person doesn't have a shirt on, doesn't have any clothes on, and they're reasonably defined in their musculature, you can go like this, depress, okay, onto the muscle, and you'll see the triangle shape exude, okay? And then you can target the center of that, but close enough, okay? So don't spend tons of time. You don't have to take their clothing off. It'll go through the shirt, it'll go through a jacket, okay, maybe not leather, maybe not like a Canada Goose emblem embroidery, but it'll go through most clothing. If you choose the vastus, just make sure, you know, like thirds, right? Middle third, slightly outer aspect, no keys, no wallet, right? It'll go through a pair of jeans, no problem. Same place you would give an EpiPen, right? So, a muscle push. So you have your dart, you have your muscle, 90 degrees, all the way in. It's a 1-inch needle. It's chosen to be the right thickness for most people. The person is very, very thin, you might feel resistance, i.e. bone, but remember they're unconscious. We slap the heck out of this person, they didn't move, right? You can just back it off a little bit and then deliver the injection. Should be done over a count of 10, nice and slow, okay? At the end, your thumb gives an extra push, which retracts the needle. So it's a single-use safety needle. Now, you're not going to come into contact with anything the person had in their body. Massage, you don't normally do that, right? When you give a vaccine, you don't usually massage it, but you're going to massage this because you want to maximize the absorptive surface area. Count for 10 seconds. The likelihood that the person is going to respond in 10 seconds is very low, unless you witness them collapse. Like you're at a party, you saw them collapse, you maybe know whether they have a drug use disorder or not. But if you identify that they may be experiencing poisoning, if you respond quickly, they could respond quickly. Okay, most of the time, I would say that's not likely going to be the situation. So we only count 10 seconds because we don't want to delay going to step number 4, which is from CPR, which you all know. Okay, remember that the face shield is for your protection. There are gloves here for your protection. The reason that there's 3 instead of just 2 is because when you evacuate the victim's mouth, right, you can open their mouth, move their tongue, scoop, and sweep, right? Now you have a dirty hand that you're gonna be manipulating with. Peel off the glove, put on the extra glove. That's what it's for, okay? Unique to that's my design. Actually, it was recommended by a person that I trained. They said, why don't you put an extra glove? I said, okay. So there's an extra glove in there for that reason, right? And so you perform your CPR. You do 5 cycles of 2 breaths, 30 compressions. You all know how to do that. At the end of that, you're going to check step 5. Is it working? Are your efforts working? Is the person breathing spontaneously, right? And if they're not, then we go back to step 3 and give them another dose of naloxone. So CPR should take 2 to 3 minutes, right? So every 2 to 3 minutes, you're doing another dose of naloxone and then another set of CPR. Hopefully, if you're in an urban setting, paramedics will arrive quickly. Depends where you are, depends how backed up they are. It may take a long time for them to arrive, which is we're just going to continue with naloxone and CPR, alternating as many times as it takes for the person to recover, start breathing, right? And if they do, then we put them in the recovery position. You're familiar with that too, right? If at any point you run out of naloxone, people bring you more, just keep going. You started with the injectable, and they bring you spray, you keep going. Vice versa, it doesn't matter, right? But if you run out of naloxone, paramedics haven't arrived yet, you continue with CPR, alternating with someone that can take some of the burden off of you, ideally, right? If they arrive, they take over, you take a back seat, you answer their questions, you get your own attention for yourself. If you're freaked out or something happened, you want medical attention, you get attention for yourself. Okay? Those are the 5 steps on how to use injectable naloxone. The only difference with the intranasal is when you come to step 3 to give naloxone, instead of drawing up a vial of the injectable, like I showed you, which just takes a few seconds, you will take out one of these, okay, peel it open, gloves on, thumb on the plunger, fingers on either side. This is not like a Dristan bottle, which you gotta pump a bunch of times to get it going. It's only a single dose in here. Okay, so if you test it, you've lost it. So thumb, fingers, gloves, fully into the person's nostrils, and this time it's a quick push because we want speed to atomize that medication, that liquid medication, and it'll absorb better from the nasal passage. Right, it's absorbing here. Count to 10 seconds, see if they start to recover. If they're not recovering, then CPR. If you have to use a second dose, alternate nostrils. It's the only difference with the spray, okay? So that's naloxone training, you guys. I'm sorry it took so long. But hope you found it useful. The naloxone is meant to be kept at room temperature. So if you carry it on your person, like with this carabiner, it's very fashionable. Put on your belt loop, put on your backpack, put on your bag, your purse, whatever. It's also a walking advertisement for conversation, destigmatization. What's that? Is that a first aid kit? No, it's a naloxone kit. What's naloxone? Let me tell you. Okay, now you can have a conversation with that person. Any questions? Thank you. When you do come to get your naloxone kits, they've got about a 2-year expiry, okay? And you can opt into getting reminders when they're about to expire. Please share this message with people that you know, people that you love, friends, family, groups that you belong to. And especially talk to your MPP, because these changes that were announced on February 9th have severely impaired our ability to do this kind of work. So I'm here pro bono today, right? I'm here because I've committed to this mission in my career, and I have personal reasons for doing it. But the changes that were announced on February 9th by the ministry are going to severely impair our communities across Ontario from being able to access naloxone. You know, the Salvation Army, the Hamilton Hub, YWCA, they all used to get their naloxone from us. They can't get that anymore. They have to go through some long-winded mechanism, bureaucratic mechanism to get their naloxone. So they don't have naloxone for probably 2 to 6 months. Except with all this paperwork and get insurance and blah, blah, blah. People are going to die. Sad. But thank you. I appreciate that. Let me know if you have any questions. Make sure you complete the form if you want to get a training certificate. And with that, I will leave you all. Thank you so much for your attention and your questions, and maybe another time. All right, thanks so much.
Thank you.
Once, right?
I didn't know that.